Now let's start with the first case. This is a young male patient who presented with shortness of breath. The case that you're looking at here is actually a common case in practice, and it's also one of the exam favorites. The first thing you probably noticed is the cardiac enlargement. This is easy, that's obvious. And in practice, many radiologists would stop there because the rest of the case could be actually discussed over a good echocardiographic study. However, you could be more precise when looking at such cases, and in an exam setting, the examiner would probably want to hear more. So cardiac enlargement is not enough. You have to decide if you could figure out specific chamber enlargement. Going to the basics, we know that the left cardiac border is formed by the left ventricle. We know that the right cardiac border is formed by the right atrium. While the left atrium lives posteriorly and it does not contribute to the borders of the heart except for one location, which is around here, immediately below the left main bronchus and hilum, where you'd expect this area to be composed of the left atrial appendage. So what do we see here in more specific terms? One of the earlier signs of left atrial dilatation is that the border of the left atrium, which should not be seen on a normal case, becomes to be more clear and visualized, and it projects to the right lateral location, giving you what's known as a double contour sign. So here you see a double contour. This contour here is the left atrium, and this is the right atrium. This left atrium is very big to the extent that you could actually outline the borders behind the cardiac shadow. Now, another thing that happens with left atrial dilatation is that the appendage that should have a normal appearance that's either straight or concave inwards would give you more straightening or convexity outwards if it's enlarged. So dilatation of the left atrial appendage in this location here. Now, one important practical point, how do you differentiate a dilated left atrial appendage from a dilated pulmonary artery, which is not seen here? The reason I say that is because these two structures are closely related to each other. So the way to differentiate is to look at the left mainstem bronchus. You could see the lucency of the left bronchus here. If the bulge is below the bronchus, you're talking about a left atrial appendage. If the bulge is above it, more within the hilus structures, you're talking about a left pulmonary artery. So we talked about two signs. Let's talk about the third sign that lots of people really know when it comes to dilatation of the left atrium. It's widening of the carina. The reason this happens is because the left atrium anatomically lives below the carina and the left main bronchus. And when it's dilated, it pushes the left main bronchus superiorly, which leads to widening of the carina here. Now keep in mind that when it comes to practice, widening of the carina due to left atrial dilatation is a very late sign. So you do not depend on that alone, because by the time you see that, it's well known that the patient has left atrial dilatation from a clinical perspective. To complete what we're talking about regarding cardiac chambers, let's look at the lateral. One very important point when it comes to oral examinations, if you have a lateral X-ray, please look at it carefully and correlate what you're looking at with the frontal radiograph. The examiner would put a lateral there for a reason, whether to show a pertinent negative or a pertinent positive. So always correlate what you're seeing here to the frontal. And when you describe findings, describe them in the view of both images. Don't start by findings that are isolated to a single view and then go to the other. Try to combine what you're talking about in a single phrase. We know from normal anatomy that the anterior cardiac border behind the sternum is actually the right ventricular border. Most of the posterior border is the left ventricular border. What you see here as a line that goes all the way down from the chest to the abdomen through the hemidiaphragm is commonly seen, and this is the IVC. Now, high up below the hilar structures, the hilar structure is here in the central area, you should not see this bulge. This is part of the posterior cardiac border that's formed by the dilated left atrium. So this bulge posteriorly is the dilated left atrium, and it confirms what you saw on the frontal radiograph as enlargement of the left atrium. A sign that's known in the literature that could be seen on the lateral chest radiograph with the left atrial dilatation is when the left main bronchus is elevated superiorly and posteriorly. So it projects in an oblique fashion posteriorly, which gives an appearance that is known as the walking man sign or the ballerina sign. Now, this is not clearly seen here, and to be honest, this is not very important when it comes to clinical practice or even in the oral examination. However, such trivia may be a target for MCQ questioning, although there are other questions that are commonly seen in MCQs when it comes to left atrial dilatation. Now, once you decided that the left atrium is abnormal, and this is a cardiac case, you have to double check the rest of the cardiac chambers. So make sure that the left atrium is not dilated in association with dilatation or enlargement of the right ventricle, left ventricle, or even the right atrium. Now, none of these are significantly dilated on this case. For example, the right ventricle does not extend to obliterate the retrosternal space. The left ventricle does not extend posteriorly as well. So the predominant cardiac abnormality is that of the dilated left atrium. Once you finish the cardiac findings, go directly to assess the effect on the lungs. That's very important because the next question would be related to what's happening to the lungs secondary to the heart. In more specific terms, whenever you see a cardiac problem, make sure you don't have pulmonary edema plus minus pleural effusions. For the pleural effusion question, this is easy. We don't see any pleural effusion here. For pulmonary edema, at a first glance, a junior eye might think that this is a normal lung. However, for seniors, especially those taking the examination, you know that dilatation of the left atrium is commonly associated with various stages of pulmonary edema. And you know that the earliest stage of pulmonary edema is known as pulmonary venous congestion. Let's stop here for a while and talk about what's normal. In a normal case, when the patient is standing, and due to the effect of gravity, the vessels in the lower lungs should be larger than those in the upper lungs. That should be the normal case. The easiest area to compare to is the left upper with the right lower lung regions. If you do that here, you'll notice that the opposite is happening. The vessels in the upper lungs are obviously way larger than what you see in the lower lungs. Look how thready the vessels are here. So this is known as the first stage of pulmonary edema. In other terms, you could also call this radiographically as cephalization, since the vessels are going cephalically. You could call them vascular redistribution. You could also call them upward diversion. So they're all the same names for the same process, which is pulmonary venous congestion, the earliest stage of pulmonary edema. Once you see that, try to comment in an oral exam about the other stages of pulmonary edema, which are specifically the interstitial pulmonary edema starting by the curly B lines and other lines within the lungs. And if they proceed to a more severe form, you'll have airspace disease, whether ground glass or consolidation, typically either in a central location, known as a bat wing, or maybe more diffuse with lower lung predominance. So in this case, you do have pulmonary edema in the form of pulmonary venous congestion. Once you finish that part in the examination, the discussion would go to the differential diagnoses and recommendations. And never forget to mention recommendations in any oral examination. So let's start by the differential diagnosis. It's not that difficult. You need to have a few reasons for dilatation of the left atrium. And the common things to think about would be mitral valve disease, whether stenosis or regurgitation. Would be heart failure, left-sided heart failure in particular, with back pressure leading to dilatation of the left atrium, and this is very common in practice. And would also be an obstructive lesion, such as myxoma. Now, a left atrial myxoma is not common in practice. However, this is one of the exam favorites, since the examination would start by the chest radiograph and then take you to other imaging, such as CT and MR, to discuss cardiac masses. Don't forget that dilatation of cardiac chambers could also be a result of shunts. An ASD does not typically give you dilatation of the left atrial appendage. However, a VSD, ventricular septal defect, and a PDA, patent ductus arteriosus, may give that, with VSD and PDA being conditions that are more likely to be encountered in patients who are even younger than this case. Now, a point to highlight when it comes to mitral valve disease itself could happen due to various reasons. But one important condition to keep in mind, especially in patients who either live in or come from developed countries, is rheumatic fever, since rheumatic fever in these areas is actually a common reason for mitral stenosis. Now, once you finish that, don't forget to mention a good recommendation that fits with the case. Now, the recommendation you mention in an oral examination should make sense. It should be something that you would recommend in daily practice. So here, the next logical step would be to recommend an echocardiogram. And then depending on what the echo shows, you'll take it from there. Now that we finished the first case in the pile, let's talk about the highlights of this case. First of all, whenever you see cardiac enlargement, try to decide if there are specific chambers that are dilated, because that's going to guide your differential diagnosis and subsequent management. Whenever it's a cardiac case, make sure that you do not have pulmonary edema. When it's interstitial or alveolar pulmonary edema, that's easy for many people. However, for you as a seasoned radiologist, you have to see the earliest signs of pulmonary edema. By that, we're talking about cephalization, which is equivalent to pulmonary venous congestion. Entities to keep an eye on when it comes to an oral exam setting are cardiac shunts, atrial myxoma, and mitral valve disease due to rheumatic fever. In practice, however, a very common reason to have dilatation of the left atrium is your bread and butter heart failure that you see every day, secondary to back pressure in the left atrium from a dysfunctional left ventricle. Never ever forget to mention recommendations, and something as simple as saying echocardiography in such a case would give you lots of marks in an oral examination.